Welcome everyone. Let me introduce my PhD topic, which is improving the success in the surgery of middle ear diseases. My name is Kata Illés, and I'm working in the Department of Laryngology, Head and Neck Surgery in the Bajcsy-Zsilinszky Hospital. My vision is the clinician use the most effective therapeutic options in the field of middle ear surgery, and my vision is investigate these therapeutic options and create high level of evidence. Here is 3 projects I am worked or currently working on to achieve my goals. So the first project is about the mastoid obliteration, and shortly about the background. So the cholesteatoma is a dangerous disease. It originates from the tympanic membrane, and it can grow into the tympanic and the mastoid cavity, and while it grows, it can destroy the surrounding bone structures, and it can cause life-threatening situations. Its incidence is 3 to 12 per 100,000 population, and the treatment is always surgical. However, the recurrence rate could be very high, and there is one conventional method called canal wall-up technique. And while we're doing this, we keep the external auditory canal intact. And there is another technique called mastoid obliteration, which is became now more popular, but there is a lack of information about this technique. So we would like to compare these methods and create and evaluate the effectiveness of the mastoid obliteration. Our clinical question is, what is the mastoid obliteration effectiveness compared to the canal wall-up conventional surgery? The patients who has cholesteatoma, and the intervention is the mastoid obliteration. The comparator group is the canal wall-up technique without the obliteration. The main outcome is the recurrency and the residual rates. The secondary outcomes are the hearing results, quality of life, complication rates, and operation time. And our hypothesis, the mastoid obliteration could reduce the recurrent and residual disease compared to the conventional method. Here you can see the methods we used and the selection of the articles, and you can see 11 eligible articles was found during the selection. And here is the main results about the recurrent and residual disease. And here you can see the mastoid obliteration can even 50% reduce the recurrent and residual disease. And this is a huge number. And this is not also scientifically, this is clinically relevant. And in the qualitative analysis, we analyzed the complication rates and the hearing and the quality of life, and we didn't find a difference between these surgeries, so the mastoid obliteration is a quite safe method. Here you can see the strengths and the limitation. This is the first comprehensive study on this topic, and more than 2,000 patients' data was assessed. And because this disease is very rare, that number is very high. And we used rigorous and thorough methodology. However, these studies were only retrospective cohort studies, and there was a heterogeneity regarding to the material used for obliteration, the surgical technique, and the risk of bias was high. So we cannot make strong recommendations. However, it seems the mastoid obliteration is a good and safe method, but the quality of the data is not enough to make it a recommendation, but further randomized trials are needed. So the manuscript was submitted to the Laryngoscope D1 journal, and it was accepted in September. And the second study is investigating the predictive factors of the success rate after tympanic membrane reconstruction. What are the tympanic membrane reconstruction techniques? Here you can see the tympanoplasty and the laryngoplasty. This disease incidence is higher, it's 9 per 1,000 population, and the success rate is around 77, but it can even 40 or 90%. And why is that? Because there are various factors influencing the outcome, and we would like to identify these possible factors and find a correlation. So here you can see the clinical question, what are the factors impact the type 1 tympanoplasty and meringoplasty? And we use the PECO framework. The P was the patients who underwent type 1 tympanoplasty or meringoplasty. E is the group of patients with the suspected factors, and C without these factors. The primary outcome is the success rate, which is the number of fully closed tympanic membrane expressed as a percentage. And how can we assess that? It's one of the most easiest things. We just examine the tympanic membrane with the ear funnel, and that's it, at the 12 months of the surgery. And the secondary outcomes are the hearing results, ear bone gap, and the air condition. Here you can see the systematic search and the flowchart, and we identified 39 eligible studies. So we have 10 analyses, and because of that, we cannot show the forest plots, only these aggregated results, and then highlighted the significant results, which were the age of the patients, the size of the perforation, the opposite ear status, and the surgeon, the experience of the surgeon. And these four was statistically and clinically significant. And I would like to highlight the last one, the surgeon experience, which is not a patient-related factor. However, it's very important, and it shows how the human resources are important in this field. So the strengths of this study, we could include high number of studies, and there was new clinical aspects revealed through this meta-analysis, and there are some limitations like correlation between these factors cannot be revealed because we couldn't do a multivariate analysis because of the lack of the raw data. However, we suggest that for the further studies to do a prospective study and try to do a multivariate analysis on these factors. So this manuscript was submitted again in December. And there is a third study I am currently working on, investigating the applicability of the fat graft meringoplasty. This will be a multi-center, one-arm interventional study. And what is the meringoplasty is also a method for heal the perforated tympanic membrane, but it's a minimally invasive technique. It's inexpensive, very easy to learn, quick, and few resources are required. But why is not used for in border field? Because it's proven effective in only small perforations. And there is no guideline or recommendation for using the fat graft meringoplasty. And because we know the sizes matters, you see in the previous meta-analysis, we would like to do this study and provide more information about the fat graft meringoplasty because it has many advantages. So here is the clinical question. Should we use the fat graft meringoplasty in medium-sized perforation? And here you can see the PECO framework. The P is the patient and with tympanic membrane perforation. The E is the perforation size medium, and the comparator will be the small. And we would like to assess the success at 1 year. And our hypothesis is that this technique can be used not even small, but in medium-sized perforations. And with using this, we can save resources, money, time, and we would like to extend the applicability of this technique. And here you can see the 3 goals, and thank you so much for your attention.
Congratulations for your progress in your presentation. I just have a question regarding your last topic about the clinical trial. Why have you decided to do just 1 arm instead of 2-arm study? You have mentioned the FGM is not usually a used technique, so don't you have a gold standard technique that could be compared to? Or so I'd like to know more about this. Thank you.
Yeah, thank you so much for your question. Yeah, there is a gold standard technique when we have to elevate the tympanic membrane and we put a fascia or cartilage under the tympanic membrane and get back. So the fat graft meringoplasty, we don't do this. We don't cut anything. We just put the fat into the hole, and that's why it's so quick and easy. And to do so, we're using endoscope. And these two methods is very hard to compare, and actually we would like to just see how this is working in small and medium-sized perforations, and this technique like a step forward. So it's this fail, then that comes, because that technique creates scarring, and maybe you use the fascia and there will be no more. So in the first step, we just using this technique, and later the conventional method, which has actually maybe higher success rate, because the previous study, when they compared it, it showed that there is no difference, but in that study they followed only 3 months, which is not enough, and they used only 1 and 3 millimeters perforation sizes, and still it's unsure.
Congratulations to your progress. That's really nice. And just an advice, because you, in your second and third project, when you report on the incidence of the certain pathologies, you use references from 2008. And so I think if you can, you should really look for another data, because decades gone by, basically, almost 15 years, so it's quite long. You know what I mean? If you have a new data reporting on the incidence, I think you should use that. Just an advice, okay?
Okay, thank you.
But congratulations.
Congratulations as well. I just have one question regarding the operation time and the first project. So you compare, you compare this canal wall-up and then obliteration of mastoid. Is there any difference? Is some technique more quick, or a resource like better for the resource? Thank you.
Yeah, thank you for your question. The mastoid obliteration lasts longer, because it's you have to collect the bone, and after that you have to put it back into the mastoid. So in its nature, it's going to be longer, but it's not that long. So maybe 20 minutes or half an hour. And yeah, thank you for your question. It's not reported in many articles, only we found one article when they compared it, and yeah, they say it's longer, and also our experience, it is longer.
How did the first and already published project change the practice in Hungary in cholesteatoma surgery, or at least in your hospital? Did anything change after this result was published?
We already have a protocol, and since years we're using the mastoid obliteration technique, and I think we are more comfortable to using this technique. We didn't change because we already used it, and I hope in other centers start to use, but to do so they needed some material. So I hope they would like to start it. And in Europe, there are courses they can apply and learn how to do. And the main center of it in Netherlands, where also my supervisor learned this technique. So I hope there are other people who would like to learn this technique.